So for this coming session, let's have the panelists take the stage. And we have Dr. Chen, Dr. Infante, Dr. Lee, Dr. Heuvalmans, and Dr. Thongcharoen.
Yeah, good morning. Also welcome from my side. So the majority of panelists have been here in the last session, so you already got introduced to them. So maybe Dr. Heuvalmans, can you briefly introduce yourself to the audience as well?
Yes, thank you. And thank you for the invitation to be here at this wonderful conference. My name is Marjolein Heuvalmans. I'm a pulmonary oncologist from Amsterdam, the Netherlands, and also part of IDNA.
So we're going to discuss a couple of cases and therapeutic management. So we'll start out with a case on multifocal nodules. So we're talking about a 77-year-old male with a smoking history of 40 pack years. He stopped smoking 20 years ago, so would in some settings fulfill requirements for lung cancer screening. He has a chronic kidney disease, stage 3, history of myocardial infarction and transitory ischemic attack. He's on anticoagulation due to atrial fibrillation and has a reasonable lung function with an FEV1 of 86%, a DLCO of 63%, and good cardiac function. So have a look at the CT scan video, please. And back one slide. And what do you see here? There's actually a video. So maybe some of the panelists or the audience. If you go back one slide.
What the answer is.
So it's basically bilateral nodules, and you can see a spiculated lesion in the left upper lobe in the size of 27 millimeters. You have a spiculated nodule on the very apex of the right side and an additional nodule of 9 millimeters on the right side as well. So if you play the video started, if you move the cursor over the CT scan and click on play, you see we did a PET-CT for further staging, and both of the lesions in the apex are FDG avid, whereas the small nodule is negative. So additionally, there's a IPMN in the pancreas. There are a few unspecific nodules in the lower lobe, no lymphadenopathy, and the CMRT was done, which was negative. So how would you proceed? So basically, the question will be whether in this situation you would just observe, do a further imaging follow-up, whether you would aim for histological verification, either by bronchoscopy or by CT-guided biopsy, whether you would go for primary resection, primary radiotherapy without any histological verification, or initiate systemic therapy. Okay, so you can scan the QR code and answer the question here. Okay, we got our first answer. That would be observation. Now it's slowly coming. So we got the majority for histological verification by CT-guided biopsy. Second would be bronchoscopic biopsy. And the minority would go for direct surgery and vote for observation. So we did what the majority suggested. We went for a CT-guided biopsy of the lesion in the left upper lobe. It turned out to be a lipidic adenocarcinoma, TTF1 positive, PD-L1 TPS of 2%. Molecular pathology turned out to be negative. So for this reason, we proceeded with surgery of the left upper lobe, performed a lymphadenectomy. Surgery was uneventful. The histology revealed an adenocarcinoma in the stage PT1C and 0M0, PD-L1 0%, and there was a KRAS mutation found in exon 2. So the patient initially had a good lung function. How would you proceed further? So maybe can the panelists discuss on that? We did an additional functional testing after the surgery. So the patient dropped somewhat with the FEV1. Which is now 57%. The LCO is 53%. And we still have those two lesions, the one in the apex of the right upper lobe and the small additional nodules. So maybe can we start with some comments on how you would proceed, starting with Dr. Infante and moving along the table?
Okay, thank you. So this is basically a moderately high-risk patient. Start off with who has already had a major lung resection. And you can see that there is an impairment of respiratory function after the surgery. So I would maybe suggest SBRT for the right upper lobe lesion, which is basically radiologically very suspicious and PET positive. So I would expect the same kind of histology. So this would be my proposal.
Okay, Dr. Thongcharoen.
Sorry, may I start with ask Dr. Chen about the first operation? Can you use your 3.0 MS for this by doing less than lobectomy in the first time for this one? They did left upper lobe lobectomy in this case. Can we do? Yeah, probably from the first operation, and I may look at a CT more carefully that we may be able to do less than lobectomy in the first place. And then we will have better lung function to deal with the other lesion.
Okay, so you would have aimed for a sublobar resection with the argument of preserving lung function for the contralateral side. That's certainly a valid argument. Dr. Chen?
Yeah, I'm the same. We're try segmentotomy first. I think that we can do that, you know.
Okay. So basically the decision to go for a lobectomy was since the tumor was above 2 centimeters, which in a situation where the tumor is unilateral certainly would warrant a lobectomy according to the data, but with the multifocal lesions, that's certainly a valid argument to proceed in a parenchyma sparing way. Dr.
Yeah,
Lau, how would you proceed?
Does this work? Yep. So I think my strategy would be a little bit different. So I think the question was, what is the right-sided diagnosis, which was more important than the left side, because that is pretty much obviously malignant. So I would have gone and done a bronchoscopic biopsy on the right and marked them, because I think in the fleeting scene, looking at the scan, they were both quite superficial. So potentially they could just both be done by wedge because they're low risk, they're sub-centimeter, and they were not FDG avid, and they are subpleural. And then that leaves more lung function to proceed with the left side. And I agree with Dr. Chen. I considered the left upper lobe trisegment as a lobe, the equivalent of the right upper lobe, and proceeded with that as a second operation when the patients still have more lung function. I think that would have been my strategy.
Okay, Dr. Heuvalmans.
Yeah, I think I'm here in a panel with quite some thoracic surgeons, so I might be here a bit. I do have a bit of a different approach. I think you have a 77-year-old patient coming into your outpatient clinic with quite some comorbidities. Now, having underwent already, well, major surgery, lobectomy. Well, I mean, you have maybe more major surgeries, but it's not nothing. You see some decline in lung function. You have 2 nodules that are, I think, suspicious in this patient, but I would take a little less invasive approach. I would prefer also to get histopathological diagnosis, preferably bronchially. And then either proceed with ablation if you have the techniques, or SABR. And I think SABR is a good option in this patient, given the age and the comorbidities. Yeah.
Okay, so in this setting today, that's the minority report as you suggested.
Honestly,
Regarding the ablation, I have a question. Do you think this is something that is ready for use in routine surgery? Calvin, you showed in your presentation, you're very enthusiastic about the technique. There was a lot of images that it's nicely feasible and doable, but actually the long-term outcome data are pretty limited. Is this something you would do in the routine setting outside of a clinical trial for an otherwise fit patient?
I completely agree. I don't think it's ready for prime time. The technique is still evolving. So, for example, applying its robotic bronchoscopy has only been done in the last year. What we need is more people mastering the technique to a high skill level and then running a prospective trial. It is only suitable for medically inoperable patients at the moment, or patients in a clinical trial. So it is not standard of care.
Okay, so I will show you what we do. Actually, you don't see the patient here. The patient was actually very motivated and fit, so we decided to proceed with surgery on the contralateral side as well. We performed two wedge resection, which the patient tolerated very well. The lung function was probably still somewhat limited due to the immediate pain in the immediate postoperative situation. Those lesions were actually, the one turned out to be a minimally invasive adenocarcinoma with a PD-L1 of less than 1%, again NGS negative, and the second one turned out to be a granuloma. So the most likely judgment by the pathologist was that it was two synchronous primary lung cancers, and therefore we decided to proceed with follow-up without any adjuvant therapy.
Yeah, how do you know that the second primary, that two, the primary, not the metastasis?
I fully agree. In this situation here, we don't know for sure because we don't have any mutations that certainly will tell us that. It was just a pathologic appearance. If we go back one slide, the distribution between the lipidic and the papillary component was different between the two tumors. And this is from the immune histochemistry point of view, rather likely the situation that it's two synchronous primary, even though we can't tell for sure in this situation. I agree on that.
May I comment on this? You normally have pathology data after resection. So you have to decide what to do, whether second primary or metastasis, without knowing what the histology will be.
Yeah.
So you have to make a decision.
Yeah. Yeah.
Okay, so let's proceed with the second case. It's a patient, again, a male patient, 78 years old. He has a smoking history of 60 pack years, stopped 18 years ago. And this is a patient which we're encountering on a more and more frequent basis with some previous cancers which were a longer time ago. The patient already had an upper lobe lobectomy on the left side in 2009 for an adenocarcinoma. NGS was negative by that time. He has a history of breast cancer even longer ago, 1982, has also some cardiac comorbidity. However, in spite of the upper lobe lobectomy, still a very well preserved lung function with a normal FEV1, normal DLCO, and also a good cardiac function. Can you start the video again, please? So what we can see here on the CT scan is the cavernous lesion in the right upper lobe, and additionally a subpleural lesion in the right lower lobe with well-looking parenchyma on the left side. Can you start the PET-CT as well? So basically, both of these lesions show the mild FDG avidity. And there was an additional small 5mm nodule with no FDG avidity. So again, the question to the audience, how would you proceed? Would you go for observation? Would you go for bronchoscopic verification? Would you go for CT-guided verification, go for direct surgery, go for radiotherapy without verification, or for systemic therapy? There's a close race between CT-guided biopsy and direct surgery. So maybe let's discuss with the panel, what's the value of biopsy in such a situation where you have a patient that is, from the functional point of view, perfectly operable. Would you see any consequences in doing a preoperative biopsy, or would you go for other therapeutic options than surgery?
I actually voted for direct surgery. In case you get an inconclusive result with a percutaneous biopsy, you have to go to surgery. If you get a positive result, you have to go to surgery. And so the patient is, despite the history, she has normal lung function, so not high risk. Well, let's say coronary artery disease is a factor, but it's acceptable. So I would rather have a direct histologic assessment during the surgery, and then would go for limited resections for both lesions. This would be my recommendation.
Any opposing views in the panel?
Well, again, here, I think I would see the patient coming in my room. He is 78-year-old, had also quite a extensive medical history. I mean, his lung function and cardiac function number-wise seem preserved, but I would still see who is coming in, who's walking in, and what is his motivation, what kind of treatment does he want to undergo? And some patients have they're also a very strong opinion as less invasive as possible. Then in this case, I would also discuss, for instance, SABR, and I think then you have an advantage when you have his pathological diagnosis on forehand. So that would be, I think, my consideration. So more like tailored based.
Okay, that's a valid argument. It's actually also interesting because if you look at European data, in general, how many patients are operated, how many patients are irradiated, I think that reflects very well the data, because in the Netherlands, there's a lot of a much higher SABR rate compared to a surgical resection rate to other countries. And I think this is very nicely reflected by the approach you're describing and choosing. So what we did in this situation is we proceeded with direct surgery exactly with the arguments that were brought before. The patient is functionally fit, and we decided, due to the more central location in the right upper lobe, to proceed with lobectomy in this situation, to have a safe resection margin and perform the wedge resection of the lower lobe. Actually, the tumor turned out to be, both tumors turned out to be adenocarcinomas, one with a KRAS exon 3 mutation, the second one with a KRAS exon 2 mutation and a KIT exon 30 mutation. So those were a second and a third primary lung cancer due to the mutational status, and the patient received no adjuvant therapy for this reason. And the surgery is actually now about 8 months ago, and the patient is still very fit and head of the local table tennis club and very active in these sports. So those were two cases to highlight the situation of multifocal lung cancer. So now I'll pass on to David for his choice.
Thank you. Okay, we're going to start a few other cases. Karen, I may be calling on you to give some comments on some of these as well. couple of the cases I think we touched on yesterday in the diagnostic session because this starts becoming a little bit of overlap in the way we think of things. You know, you think of it both diagnostically and sort of from the therapeutic point of view. But let's just see. Some of them we'll go through pretty quickly, and others we're going to spend a bit more time on. Case 1. Really? Okay. So here's the initial scan. Small nodule in the left upper lobe. 6 years later, a little bigger. 14 years later, continues to grow. And this is the pattern, right? 3.5, 4.5, and 5.9 millimeters over the course of 15 years, right? This is, and the doubling time, if you calculate it, 2,000 days. And this is, I would say, pretty persistent. So the question with all of these cases, and it came up before, but what feature impacts decision-making for taking action? Is it the absolute change in size? Meaning this thing clearly, when you look at time 1 and time 3, there's a pretty important size change. Is it the growth rate? Is it the morphologic features? Or is it some kind of probabilistic measure of chance of it being benign?
Just use the camera.
They came into the they were about 50 years old when they started. So growth rate, doubling time. So here you're saying it's growth rate is the most important, even though it's clearly changed. Do the panelists have anything important to say about this, or do they agree? Basically.
Well,
I think also this is a bit more like tailor-made. I don't completely agree that it's only growth rate. It's also depending on your patient age, your patient fitness. I mean, a slow-growing tumor in an 85 years old is something different than a slow-growing tumor with a persistent growth in a 40 or 50-year-old healthy individual.
Sure. This is a person that's fit for surgery, fit for treatment. So let's just assume that.
It's very round.
Does that matter to you much in this case?
Because I'm not thinking about an adeno that's transforming in a ground glass background. I'm thinking this is either a hamartoma taking its time to prove itself, or it's a carcinoid tumor. So I have those two differentials in my head.
And if it looked a little more nasty and it's still growing at a very, very slow rate over 15 years, would you still want to do something? Or would you still be willing to follow this? These are tough questions. I get it. But, 15 years, 2,000-day doubling time, pretty persistent. Even if it looks a little angry, would you still be saying,
I
got to
think
take it
even
out?
In this case,
Would you rush to the OR with this
biopsy.
patient?
Well, I think we should biopsy it.
Now you would biopsy it.
I would biopsy it if it looks like this, or if it looks a bit nastier.
Okay.
Because you mean after seeing it grow a bit? Yes.
Yeah, I mean, there were scans in between also. So it's persistently just like the turtle, just going along very slowly.
how big is it? You said 5 millimeters.
How big is it now? I forgot.
Yeah,
How big is it now? Yeah,
David,
it's bigger.
Yeah, it's bigger, but
It's bigger.
David, I'm asking because
I can't hear what you're saying.
David, I have a comment. I think this was mentioned yesterday about the biology of these tumors, and the problem is it's not linear.
It's
right.
linear.
You can have an explosive
we have
transformation.
cases. In this case, I showed it, and I was thinking of your comments yesterday. In this case, we have scans in between. This patient was coming back each year.
Right, but even so, I mean, it can be 10 years, it can be 12, but all of a sudden the tumor can acquire a mutation that transforms it. And so if you have a tumor that's growing, I think you don't have a crystal ball to know which one is going to transform itself into an explosive, invasive, and aggressive tumor at some point. And so the better part of valor is to take it out if it's a growing tumor.
Why not a PET scan? I mean, this is why I was asking how big it is because
Yeah, these remain very interesting comments. Your comment, Luis, is particularly interesting to me because yes, that's possible. I agree. It is possible. And sometimes tumors just explode. But when you do things like staging systems and medicine in general, you don't think of the exception. And what you're describing is pretty much the exception. You have a case like this where it's just, you know, to me at least, it's hard to think it's going to explode. It could, I agree. And so, but that clearly factors into your calculation. It's I say, it's a very interesting. We're going to move to the next guy. I have a lot of cases to go through. I'd rather show more than get, we're following.
okay.
Now, this one's a little different and we'll just go quickly. I have a feeling Dr. Chen may have something to say about this one. Just have a feeling. Small non-solid lesion in the left lower lobe. 2 years later, non-solid lesion in the left lower lobe, maybe a little bigger, definitely a little bigger. Now it's pretty clear by 5 years, you can see it's getting a little spot on the top of it. And now 7 years later, clearly there's something solid there, right? Patient is very reluctant to go for surgery. Doesn't want to do it now, wants to wait, see what happens. What would you tell this patient? Oops, here it is. Here's some time. This is overall 7 years. He's got a 4x2 solid component on the top of it. Overall, the size has not changed very much. Patient's in good shape, easily tolerates surgery, but really doesn't want to. And so now, how concerning is a small solid component? Is it safe to follow this patient for another year? Do you want to follow him in 3 to 6 months? Would you be willing to do that? Or would you go for immediate intervention? So most people are that's pretty close, but willing to give it another 3 to 6 months, but slight majority want to go in immediate intervention. The patient asked me, by the way, and said, I really don't want to do it. I want to follow for another year. I would say to the patient, it's safe. That's what I would tell him. But I would have preferred he did something. Dr. Chen, what would you say?
Yeah, I repeat my statement. Persistent, slowly growing. We cannot 100% for sure, but 95% it turned to be malignancy.
We agree. We're I think
For
in
this
group
patient,
thinks,
because of the location in the left low lobe. The low lobe is very important for people, especially for, we can do earlier, we can do just a veg resection. We don't have to segmentectomy. If some component come up or, maybe you can cure a patient, maybe you lost more lung parenchyma. So I prefer, you do, you can compare how the patient, what the estimated his life expectancy. We need seeking the time, the QED time window, and also the less lung parenchyma less, the procedure. We do the procedure as less as possible.
see, my question is a little more nuanced. I think everybody here knows or is pretty confident, 95% or even more. This is adenocarcinoma. Everybody agrees.
Yeah,
with-
if follow up, I don't follow up in 2 or 6 months, even 1 year, it's safe.
Right. That's where
Yeah,
I'm driving.
or in my
I wouldn't recommend it, but
patient want to have surgery, just come to see me next year. You don't have to every 3 or 6 months to repeat the CAT scan. The CAT scan still, do a little harm to you.
right. The question I was driving at was, we understand this is adenocarcinoma, very likely. The solid component is slowly moving. I'm still pretty confident, or even very confident, that in a year from now, it's still going to be very safe. But I would have encouraged them to do something now.
Yeah.
I think, okay, let's try another case. Karen, get ready. Here's a lesion in the left upper lobe. He goes for biopsy. Biopsy has a little pneumothorax, has a bit of hemorrhage around it, comes back adenocarcinoma. We get another CAT scan before the planned surgery. And all of a sudden we see in the areas where there was hemorrhage, we see new nodules there. You see they're circled on the middle and the right slide. So now, these are, in my mind, highly, highly likely to be metastatic disease. Airway spread from the hemorrhage. So now, how would you stage and treat this case? Surgery alone? Would we call this a stage 3B? Or sorry, 2B, T3N0, stage 3A, T4N0 lesion, surgery and adjuvant chemo. How do we treat this case? Because clearly this is metastatic disease,
What
airway
was the time
spread.
interval between the scans?
Oh, weeks. Month, whatever. I mean, it's not long,
No.
not long.
No.
Surgery alone seems to be the winner. I will start this one, Karen. What do you think? Somebody give Karen a microphone, please.
Metastatic. Most likely metastatic, as you said, because they're right in that same area. So I would have chosen, and I did choose the second one, to where it's surgery now followed by adjuvant. However, I would say that neoadjuvant chemo IO is really the standard of care, and you really need to know if the patient has an EGFR or ALK. So we would most likely biopsy that, determine whether or not it has any actionable mutations, and then try to give the patient neoadjuvant chemo IO. If they had an actionable mutation like an EGFR, then we would give chemo followed by IO. As I said, most at least we're in the United States, most of us are really going to that neoadjuvant setting. So
our medical oncologist feels that some type of chemotherapy or
chemo IO
is necessary.
I mean, you can do it afterwards, but really the movement has been to the neoadjuvant space to see about path CR.
Okay, I want to hear from one of our two surgeons, or proximal two surgeons here.
Well, I would like to be sure that those satellite nodules do represent metastatic disease, so I would go for surgery first, in the hypothesis that they are maybe a reaction to the hemorrhage that they had.
So you would potentially biopsy again?
No, I would go to surgery.
We could get another set of.
I would consider it probably stage 2B.
Well, you'll know it when you operate. You'll find out.
Yes, and then you have the pathology, and you know.
But let's
maybe
say-
it's stage 1.
My question is, do you think of these airway spread tumors as now requiring more therapy, adjuvant therapy? Or do we consider this stage 1, it's out now, we did the lobe, it's out, done?
No,
Do we need to do adjuvant therapy?
I would consider
Do
adjuvant
you think
therapy
adjuvant therapy is necessary at this point?
if it's pathologically proven, of course.
Any other disagreements, or does everybody agree that this needs adjuvant therapy?
Yeah, I agree with the neoadjuvant. And I think I see in our
You agree
oncology-
neoadjuvant for this one?
Neoadjuvant.
Yes,
Neoadjuvant.
in our oncology MDT, we will have a great discussion on this case, and it will take us like 10 minutes to decide, because half will opt for lobectomy first to prove the malignancy of the satellite nodules, and the other half will go with Karen and go for the mutation analysis or the NGS and PD-L1 preferred, and then neoadjuvant and then surgery. That will be what happened.
Yeah.
And
Again, adjuvant IO therapy
Boy, the oncologists are all lined up here. Ray, Ray has something to add to this.
If it is indeed weeks apart, would suggest that the nodules are, I mean,
They were.
Yeah,
They were.
This is what I think.
Yeah, no, they were.
I also want to say that if you seed it, a seeding is not a metastasis. A
Right.
seeding is a direct. Well, it's not hematogenous or lymphatogenous. You've hygienically caused it. You split the tumor. So do the clinical trials? They don't apply in this situation then.
To me, that's the crux of the question.
I
Do we think of those lesions as the same type of metastatic disease as we do something that's, spread differently? Certainly, this is not the same as a blood-borne spread. It's an airway spread. So
I'm also not sure whether we really can call it 2B, because it's definitely where the hemorrhage was. So it's probably a local spread or even a local dissemination through the biopsy. And therefore, I wouldn't like to call it 2B.
well, we don't have another name for it at this point, but it's a
Debate.
okay. Let's move on to another case because I have a bunch. I think we'll try to get them this kind of a case. Let's see. Pre-op left lower lobe adenocarcinoma. And you can see it's got a bit of a part solid kind of look to it. Might call it solid, but there's some soft stuff around the edges. This patient, let's see, had a wedge resection in the left lower lobe. They took it out, and now you can see, let me just go back and see what year that was. 223. That's the primary lesion. A year later, you can see there's a suture line from the wedge resection, and you see there's a non-solid lesion there. I think that's a little vessel on the bottom of it. And a year later, and there's 2 or 3 more. So is this the same kind of situation now? We've got 3 non-solid lesions in that remaining left lower lobe. Would we just go in now and take this out and say, hey, let's completion lobectomy? Or do we follow what I presume Karen would say is do some kind of chemo IO on this? We didn't rebiopsy it yet. Do you have a question as to what this is? Is this a serious concern in your mind that these are not some type of adenocarcinoma now? And I'm asking it, genuinely. We're not here for the amateurs. These are good cases. Or panelists, is anybody here concerned that this is not adenocarcinoma, those 3 non-solid lesions? Do you think we need to prove it, or are you?
I think the chances
Convinced.
are high that it's adenocarcinoma, but they don't appear like typical metastasis from the previous one. So here I think there could be like new primaries or.
Not only does the radiologist spread these tumors erogenously, I think the surgeons are capable of doing this as well.
Pretty good.
So surgeons, what do you guys think?
So,
Oh, please.
So I think that's where I will get Kelvin on board. The beauty of it, because you can then do your navigational bronchoscopy, biopsy this lesion, get your KRAS and your EGFR mutation on this, and then if it's positive on immunotherapy, I'll get it to Karen.
So
Because
Kelvin,
obviously there's lymphatic spread here, there's high likelihood of that. And so I think that will be a safest way to get
you
these.
said the word lymphatic spread.
Could well.
I wouldn't you think this is erogenous through the airways, not through the
But
lymphatics?
at the end of the day, I think the ultimate answer is looking at the mutational analysis, whether it's erogenous or whether it's lymphatics. Yeah.
So you think it's an issue of mutations as opposed to just take it out and be done with it? Dr. Chen, would you say just take it out, or do you think we need to do chemotherapy or chemo IO?
Here's how the surgeon sprayed that tumor. I don't think that sprayed the tumor. What kind of procedure they have done to spray the tumor? If my case, I would just follow up.
So what was your recommendation be for this patient
Just follow
now?
up.
Take it out,
No, follow up.
follow up. Leave it alone right now and
Yeah.
just keep following.
Now, leave alone and follow up.
Any other thoughts on the panel? Let's see what the audience says, by the way. How would you stage and treat this? Stage 1, surgery alone. 2B, surgery and adjuvant. I didn't have a leave it alone option. Okay.
No. You want to give SBRs?
The surgeons are winning here. Even though they didn't want it, we're telling you guys, this is a rare situation, isn't it? We're telling the surgeons to do something. Okay, let's go to a next case. This was a completion lobectomy, sorry. This patient went for a completion lobectomy.
And, what was the final pathology?
There were little adenos.
Okay.
Yeah, I'm right. I'm right.
Let's see if I can remember this case. Prior to surgery, this is a right upper lobe lesion. Oh, yes. Patient had wedge resection. There's the suture line. This is 6 months post-surgery. We see a little dot forming, not quite in the suture line, but outside the suture line, but in the neighborhood.
Yeah.
Gets bigger. What's the next step? Adenocarcinoma.
There is no ablation choice.
It was malignant adenocarcinoma that lesion. I don't know it offhand. Don't know. What? Adeno. I don't know I don't remember anymore. It was an adenocarcinoma. It was a stage 1 adeno. So we have some following biopsy. Okay. So close between continued follow-up. It's a tie or straight to surgery. Okay. So a lot of people would say, Kelvin, get out your bronchoscope, but we're still old fashioned. So we biopsied this. It turned out to be adenocarcinoma. And now what's next? Do we go completion?
Still no ablation.
Do we get molecular testing? Do we do adjuvant therapy? We're seeing a lot of these suture line recurrences, near the suture line recurrences. What do we do with these now? And we're catching them pretty early.
Actually, does the staple line affect your
We-
radiation?
they'll get the molecular.
The metal line.
I think they can do it too close to the.
So we operate on these. That's the idea. Completion lobectomy on a case like this. Are we doing that with all our suture line recurrences or these small near the suture line recurrences? What is kind of the standard for how we handle these local recurrences? Dr. Lau, why don't you give us some advice?
David, I don't think there, the standard care for this kind of procedure. I do believe, during the first surgery, surgeon try to, keep lung at, as much as possible. So too close to the tumor and, squeeze the tumor and spray.
Yeah, I guess the question is, why did the patient have a wedge resection for
Yeah,
a
yeah, the
solid
first-
nodule in the first place? If it is because they could not have tolerated a lobectomy, then you can't really do a completion lobectomy. Then that's a different story to the patient is fit and can have a completion lobectomy, fit with, young and fit, then yeah, a completion lobectomy.
You're questioning why you had a wedge for a tumor like that?
Yes.
Really?
Yeah.
You all would have done lobectomies on that? I'm amazed, really.
Yes.
Our surgeons try to do wedges as often as they can. That's very interesting. Do we have any other surgeons in the room that would say wedge is fine? I'm surprised. I'm listening. You would do lobectomies on that. This is not like a 4 centimeter or
Or a
3 centimeter tumor. This is pretty easy to wedge out.
That's
I
superficial.
think you have a higher risk of local recurrence with wedges. So I would, if possible, recommend a segmentectomy, which is sort of a compromise. So this is, but I realize in the right upper lobe, this is more complicated.
The bigger point I'm getting at, though, is you have something, a recurrence nearby. What's the way we treat these recurrences? A very localized recurrence post a wedge, whether it was a little, let's say it was a little smaller, it was an easier wedge. Now you have a local recurrence. I mean, that happens. What's the way we treat that?
After a wedge resection, you're going to have a lot of scar tissue. So it's normally you end up doing a lobectomy, completion lobectomy.
Completion lobectomy.
It's difficult to save.
But do we do adjuvant therapies on these? Do we try to get tissue first and do adjuvant therapy, or do we do neoadjuvant routinely on this? What do we do? You're saying not to do it on this?
No.
Once we take it out, you wouldn't do any adjuvant therapy on this, but you would with the non-solids. Okay.
Nobody has a
interesting to me.
crystal ball.
I think this is a very small recurrence.
Yes.
In a way, it's also a shame to take the whole lobe out. And I think my oncologist would have something to say about irradiating it.
Yeah, I think in our MDD, the radiation therapist will come up and say, I can also probably do some saber here.
Yes, we have a radiation therapist in the audience. What would we do? Would we radiate this?
This case, so I agree with the doctor that for the resurgery, sometimes it's difficult to find out and there is a scar on that. So for the radiation, this is quite easy to do that region. I will do the saber for this case.
I just want to say, we just published a little article on how to treat those sutureline recurrences. It's a very interesting article. And we actually showed that the results are pretty, I mean, it's a very small number of patients. We're talking about 14 patients, 7 underwent surgery and 7 underwent radiotherapy. And both groups have done very well and with the same amount of, both groups have been good and no recurrence, and we didn't have enough numbers to show a difference between those two techniques.
So Louis, what would you say we should do? You now have an article to refer to. What would you recommend that we do?
David, if this recur, I agree with radiation, but this is what the surgeon left behind.
Yes, so the
we need to
surgeon
face
has
out
to fix it.
by ourselves.
And just for everybody, I picked these cases to be really, I understand there's no right answer. Okay, let's look at another one.
Well, one thing, I think it's very important here to go in discussion with your patient and ask for his preferences and try to explain the differences between the two treatments and what he might or may not expect, and see what his preference is.
Yeah,
Agree.
we can lead
Also, I want to say those
Yeah.
patients are doing pretty well
Of course,
compared to all other kind of recurrence. This is an important point.
Yeah. There was a day when we used to say, once a patient gets a recurrence like that, it's finished. Now we're saying that they do very well. Okay, here's another case. Right upper lobe lesion, and you can see it's right on the fissure. And if you notice, there's a little bit of non-solid on the other side of the fissure there. This patient went for surgery. I don't know that anybody noticed that little bit of non-solid on the other side of the fissure. Went for surgery. And now you can see right there, you can see the lower lobe. That's a little bit of middle lobe above the neo fissure there. And there's that non-solid area right there. That's 2 years post-lobectomy. What do we do with that now? What's next? You can see it's right where it was. It wasn't noticed by the surgeon, but when he went to surgery, I asked the surgeon later on, was there any problem with that lobe coming off? It wasn't attached. There was nothing. Easily came off. Do we follow in 3 months? Do we follow in a year? Biopsy, radiation, surgery? What do we do with this case? My first question, actually, let me just ask the panelists, and just, are you pretty convinced this is, and it was an adenocarcinoma, by the way, the original tumor that was taken out. Are you convinced this is an adenocarcinoma here? Do we need to prove anything, or are you convinced that that's what it is?
Was the
I
first
think it's
report
highly likely.
incomplete?
Highly likely, I think.
Excuse me?
It's highly likely.
Highly likely. Okay, so what's next? We have, the majority said, just let's keep watching it. It's non-solid. Keep watching it. Nothing's going to happen. Surgery had very little. Interesting. Okay. We have a skeptical audience. Yeah, we got one.
Can I ask a quick question? So was the report of the first excision positive margin?
There was invasion of the pleural surface. There was some invasion of the pleural surface.
Because the debate in the MDT always is, positive margin, what do you do next?
And it's invasion of the visceral pleural, by the way, right? It's only visceral pleural. They didn't check the other pleural surface.
Dominant in follow-up, no matter 3 months or 1 year.
So follow it in 3 months, or
Yeah,
everybody's comfortable doing that.
3 months.
Okay.
I would prefer, yes, I would prefer 1 year follow-up. 3 months is just
Yeah, you can do that.
too short. Yeah. And then I think in like in Southeast Asia, there are much more incidence of non-malignant lesion. So we found it's not uncommon to see a TB or any kind of infection as a nodule like the GGO like this. So in my experience, I would like to follow up first.
Okay. I want to show one more case because we're running out of time, and it gets to the same idea as this case. Here's a lesion, solid. Again, this is going to be an adenocarcinoma. Notice what it's hot on the PET scan. It's whatever, 2.5, 3 centimeters in size. You can see what it's doing to the fissure. It's kind of actually pulling it in. So clearly there's attachment to the fissure. This patient goes for surgery. Regarding the area of contact. Now there's an area of contact with the left lower lobe, right? But the surgeon says it came off easily. Came off easily, there was no problem. Do we do anything regarding that lower lobe where there was an area of contact and the pleura was pulled in? Do we say nothing additional, just surgeon did the lobectomy and we're done? Estimate the location and do a wedge of the left lower lobe in that area where there was contact? Label that area and then wedge it, or at frozen section, see if there's invasion. And if there is invasion of that visceral pleura on the upper lobe, then do something on the lower lobe. So if we saw a little bit of invasion on the wedge, on the frozen section, would you do something different? That's really the question. We have to do something about that lower lobe where there was an area of contact and no obvious anything. Is this something you worry about when you see these areas of contact? Again, this is really a surgical question. Fred, when you saw a tumor, I should have told you this 20 years ago. But yeah, these areas of contact where it used to be, hey, it falls right off. I'm not worried about it. But should we be worried about it?
I mean, it's stuck.
It was not stuck.
No.
It was not stuck.
Came
It
up
fell right off.
with no sign of.
No sign of anything obvious.
Okay. Then I would do nothing.
Do nothing.
Because if you see the imaging like this, it's clearly retract the pleura like that. it usually means that the fissure is complete. It's just contact.
The fissure was complete, it fell off easily.
Yes, but if if it is not complete, it will not be bulged like that.
And what if we said, would you want to get a frozen section and see if there's invasion of visceral pleural invasion on that side? Would you care?
I wouldn't do frozen section. That I usually do nothing except if there are any intraoperatively, you see something,
So
accidental, then we do wet right away.
So
If
here's
they're
what
not,
happened. You can see in the picture on the left side, you see the PET scan. That's where it was touching. You see the hot area in the PET scan? It's SUV max. That's where it was touching the other lobe. And that was another tumor that grew in that spot. So this is something that we're starting to really think about. What do we do with these areas of contact, especially when you see it's deforming the pleural surface? And we have a whole series of these cases now that we're reevaluating. Anyway, I'm going to leave it at that and on to the next session.